I'd like to thank all of you for attending this live stream event. My name is Nikolai Bildzukewicz. I'm a foregut surgeon here at Hoag. That means I operate on the esophagus and stomach. I've been at Hoag for approximately 8 years. And I'd like to thank you all for being here again today. I want to spend the next half hour or so talking to you about something that's near and dear to my heart, and that's reflux disease and how it progresses to esophageal cancer. And then spend a little bit of time about talking what treatment options are available to treat this disease. So we'll go ahead and get started. So most of you probably know what reflux disease is, but reflux in of itself is a normal physiologic process. So we've all had meals at the holidays and have experienced a little bit of heartburn, which is normal. Normal physiologic process, and it actually has some health benefits. But it's when the reflux causes troublesome symptoms such as heartburn or regurgitation or difficulty swallowing, it's when it really becomes a disease. And as many of you are aware, that the symptoms can be debilitating, and if left untreated over time, can progress to esophageal cancer. So before we dive into further about reflux, let's take a little lessons of anatomy. So you can see here on the left is a diagram of the human anatomy showing the esophagus, which is a muscular tube that carries food down through the chest, passes through a hole in the diaphragm, which is the muscle responsible for breathing, and then passes into the stomach. On the right-hand side, you can see a little closer area, which is called the lower esophageal sphincter, and this is the area that I want to focus on. So a normal sphincter or valve, all right, creates a barrier against reflux, right? So this should be a one-way valve, meaning it opens properly to allow food or drink to go into the stomach, and should close properly when you're done eating to prevent reflux. So I want you, if there's one take-home point from this talk, I want you to understand that GERD is a disorder of the lower esophageal sphincter, or simply the valve. It's not a disease of too much acid or too strong of an acid. Again, the problem is the valve. So why is the valve weak? Well, we really don't know. And unfortunately, no one's really doing a lot of research into this, but we do know that it weakens over time. We do know that reflux disease can run in families. And there's a strong association with hiatal hernias. I could probably spend an hour talking to you about hiatal hernias, but it's where that valve, instead of remaining in the abdominal cavity, is shown there on the right side. It herniates or bulges up into the chest. And if you have a hiatal hernia, you have about a 60 to 80% chance of having reflux disease. So the two go hand in hand. And the good news is the treatment fixes both the weak valve and the hiatal hernia. So you may be wondering, how do you know if you have reflux? So often if you see your primary care provider or a gastroenterologist, there's a slew of diagnostic studies. Probably the most important study is an upper endoscopy. Right, this allows us to screen for complications of reflux disease before they become symptomatic. Most importantly is a pH study. Right, this can be done with either a 24-hour catheter or more commonly what we call a 48 to 96-hour pH Bravo test, which is wireless. This is the gold standard in diagnosing reflux disease. It basically measures the amount of acid that is present in the distal esophagus, again over a 24 to 96-hour period, and really gives us an idea of the severity of your disease. Then we want to get some idea of the motility in the esophagus, and this is usually accompanied by an esophageal manometry, which is another probe-based study that gives us a very detailed look at how well your esophagus peristalsis removes food into the stomach. And then an upper GI or barium swallow, or here at Hoag we have what's called a video esophagram, where you go to radiology, you drink some contrast, take some pictures, and even record a little bit of video, which gives us a really good look at how well you swallow. These are all important studies in terms of working up someone with symptoms of reflux disease. But as seen there at the bottom, most of the time it's the symptoms that will drive patients to see their providers. So the most common symptom is being heartburn, but this is not always present. About 20% of patients with reflux disease never experience heartburn a day in their life. Regurgitation, this is the physical process of fluid or food coming back up the esophagus into the back of the mouth. Epigastric pain, which is pain in the upper abdomen. Patients may experience a bitter or bile taste in their mouth. They may just have chest pain. About a third of all ER visits for chest pain, where people think they're actually maybe suffering a heart attack, are actually due to reflux disease. Patients may experience difficulty swallowing, which we call dysphagia. All right, they may have nausea and vomiting or sore throats. There may be some weight loss. That acid can make it all the way up into the mouth and get into the lungs, so it may exacerbate people's asthma. All right, patients may have recurrent pneumonia, can have bronchitis, a chronic cough. Several times a year we get referrals from the dentists who notice that acid reflux is eating away at the enamel on their teeth. They may have bad breath. They may have voice changes that the acid can affect the vocal cords, excessive belching, and they may also just experience what we call a globus sensation or a lump in the throat. So unfortunately, if left untreated, reflux disease over time can progress to several complications. As you can see here on the right, this is a picture of what a normal esophagus looks like on endoscopy, a nice healthy white pinkish kind of tissue. But over time, if the reflux is left untreated, it can cause erosions to the esophagus or esophagitis, as shown here in the next picture, which is generally complications of reflux disease. Furthermore, if left untreated over time, repeated bouts of acid damage and scarring over time can narrow the lumen of the esophagus and form a stricture. Again, this is scarring. And again, this is seen over many, many years and generally. And as you would imagine, it leads to dysphagia or difficulty swallowing. Over time, untreated reflux can also cause decrease in the strength of the musculature of the esophagus. So the esophagus becomes less effective in propelling food and liquids into the esophagus. And this is thought to be mostly due to bioreflux, but again, as you would imagine, this causes trouble swallowing or dysphagia. Furthermore, as I alluded to earlier, the acid can make it all the way up into the mouth. As shown there on the right, you can see that the diagram of the stomach, and the acid can travel all the way up the esophagus and up into the back of the mouth and can eventually affect the larynx or voice box, again causing voice changes and make its way down into the lung. So again, as I alluded to earlier, this can exacerbate people's asthma. We've had patients who have asthma that's exacerbated by their reflux. They undergo an anti-reflux procedure and they're able to throw out their inhalers. Chronic cough, again, recurrent pneumonias, and unfortunately some patients progress to pulmonary fibrosis, which is scarring of the lungs. And unfortunately, the only treatment for this is a lung transplant. Again, ear, nose, and throat problems, voice changes is something that we frequently see, hoarseness or usually like a raspiness to the voice. Patients may get recurrent ear infections, and again, a chronic or recurrent sore throat. These are all well-known complications associated with reflux disease. Probably the most feared complication is Barrett's esophagus. Barrett's esophagus is a change in the lining of the esophagus. This is where the lining changes to look more like that of the stomach or the intestines. So it's sort of a protective mechanism against the chronic exposure to the gastric acid. But unfortunately, it's a precancerous lesion. And again, this is thought to be due to mostly bile reflux, not necessarily to acid. I tell my Barrett's patients you have to know one of three things. Either you have no dysplasia, low-grade dysplasia, or high-grade dysplasia. Dysplasia is basically a way of looking at describing cells under the microscope, and it's simply described as like chaos under the microscope. So meaning no dysplasia, there's no cancerous changes. Low-grade dysplasia means some of the cells are starting to look a little bit like cancer. And high-grade dysplasia is pretty much the step before invasive cancer. So if you have no dysplasia, you just have run-of-the-mill Barrett's esophagus, as you can see, you still have a significantly increased risk of developing esophageal cancer, right? 40 times greater than that of the general population. There's turns about 0.5 to 1% risk of developing cancer per year. Again, very low, but at 10 years, that's about a 5 to 10% chance of developing cancer. As you would imagine, if you have low-grade dysplasia, you have a slightly higher risk. Again, more of the cells are starting to look like cancer, and about 2% risk per year. But if you have high-grade dysplasia, all right, and in fact, about 40 to 50% of the patients at this time will actually have invasive cancer. This data kind of comes from studies that were previously done when we used to do esophagectomies or surgical resections for high-grade dysplasia. And studies done at that time, actually, the pathologists were able to find a focus of invasive cancer up to 50% of the time in the specimen. Next slide. So if you have a diagnosis of Barrett's esophagus, what do we do? Right? As of itself, Barrett's esophagus is asymptomatic. So because of the very slow progression, if you have a diagnosis of Barrett's, we generally ask you to come back every 3 to 5 years for biopsies. Right? As you would imagine, if you have low-grade dysplasia, we'd want to surveillance you a little bit more often. So we ask you to come back every 6 to 12 months. However, and if you have high-grade dysplasia, surveillance was initially at 3 months, right? But as you imagine, patient compliance can be an issue. Patients don't generally want to come back for an endoscopy every 3 months. As I just mentioned, historically we used to do esophagectomy, but now the standard of care is RFA, or we call radiofrequency ablation, where we go down and we're able to burn off the Barrett's esophagus, or EMR, which stands for endoscopic mucosal resection, where we're able to resect that tissue endoscopically. I will tell you that RFA and EMR have a more pronounced role for even low-grade dysplasia as well. But unfortunately, a fair number of patients will progress to esophageal adenocarcinoma, and if it's caught early enough, they're a good candidate for an esophagectomy or surgical resection. But unfortunately, some patients present in an advanced stage, and all that we can offer is palliative measures at that point. So what's the risk of watching and waiting? So as you can see here on the left, you can see the normal esophageal tissue with a tongue of Barrett's esophagus at the bottom of the picture. But then you can see occupying the top part of the picture is a nearly circumferential tumor, evolving in a background of Barrett's esophagus. On the right side is a picture of a surgical specimen of an esophagectomy that involves the distal 2/3 of the esophagus and this top part of the stomach. It's a very big procedure. It's the biggest procedure we can offer. We do it minimally invasive, but obviously the goal is to not get to this point. So where do we stand today? So it's estimated that this year there'll be close to 19,000 new cases of esophageal cancer. But if you look at the cancer popularity list, it only ranks about or 1% of all new cases of cancer in the United States. So again, it's about number 18 on that cancer popularity list. And as you can see, it's estimated there's close to 48,000 people currently living with esophageal cancer. The average age at diagnosis is 68. Right? Barrett's esophagus is the primary risk factor for esophageal adenocarcinoma. And as you can see here on the right, there's been a dramatic rise in the incidence over the last several decades. You may not be able to see too well, but the bottom graphs represent the incidence of some more common cancers, such as prostate, breast, and colorectal and lung cancer. But as you can see, that top pink line there that's been climbing over those several decades, it represents a 600% increase in the incidence of esophageal cancer within the United States. So before we move on to treatments, I just want to summarize the progression of reflux disease. So over many years of reflux of both acid and bile, right? Again, the patients develop, esophagitis, which initially can be healable with medications, and then becomes non-healable, and eventually over many, many years, usually 10 to 15 years, can progress to Barrett's esophagus. And then again, Barrett's esophagus can progress from low-grade to high-grade dysplasia, and over time can progress to cancer. And again, we kind of just have a watch and wait mentality, just bringing in the surveillance endoscopies to screen patients for Barrett's esophagus. But unfortunately, Barrett's is a precancerous lesion. I do think it's time that we start treating it as such. So that ends the depressing part of my talk. We'll now move into the surgical treatments. So what are the surgical treatments for reflux disease? So generally, if you see any provider, we'll ask you to modify what you're eating and modify your lifestyle. So we ask you to avoid everything that we like to eat in our half of the world. So avoid all the spicy foods. We ask you to avoid caffeinated beverages, fatty foods, so no more In-N-Outs. For all the Italians, we ask you to stop eating your tomato-based and your marinara sauce. We ask you to avoid fruits, specifically citrus fruits, no more chocolate, no more alcohol. You got to cut back on the carbonated beverages, no more overeating. And then even some medications can do this. All these foods have byproducts that when broken down actually relax or open up that weakened valve. And that's how the mechanism, how they promote reflux. But unfortunately, this is not very successful. Only about 5% of patients are able to really achieve some improvement in their quality of life with modification of diet and then lifestyle modification. The other thing being that we'll ask you to raise the head of your bed up so that you're not subjecting your esophagus to that much reflux at night, period. But most of, if you seek any sort of a medical attention, we'll sort out some sort of medical therapy. And antacids were the initial drugs that came out. These are your Tums, your Rolaids, and your Pepto-Bismol. These are the drugs that were originally came out in the mid-70s. And these are the drugs that are good for if you're experiencing heartburn or a social situation. They act pretty quickly, but they don't really have any long-term relief. H2 blockers are the original drugs, right? These are the Pepcid, the Zantac, the Axid, and the Tagamet. But most patients will go straight to the proton pump inhibitors, or what we like to call the PPIs. These are the Prilosec, the Nexium, Acifex, Protonix, and Dexilant by prescription. The proton pump inhibitors are about 20 times stronger than the H2 blockers. So the medications work by reducing the amount of acid in the stomach, right? And if you're like most patients, the relief is generally only temporary. Patients usually require escalating doses of medications, meaning usually they would start out taking it just once a day, and then they have to take it twice a day. And then often necessary, it's to change medications, right? Or maybe if they're on a PPI, then they start taking an H2 blocker at night. So it's a very typical role. But are patients satisfied? This is a study that was a multi-center randomized controlled trial, which is the ideal study from a medical standpoint in terms of quality. And as you can see, a significant number of patients, over 5,000 patients. Now, the whole point of this study was to look at comparing esomeprazole, which is Nexium, versus lansoprazole, which is Prevacid, and its ability to heal esophagitis as well as to treat heartburn. And if you look at the graph on the right, you can see that Nexium was slightly better than Prevacid in achieving those goals. But as you can see there by the orange arrow, there's a significant gap of patients, anywhere from 30 to 40% of patients that are not satisfied with their medical therapy. And this has been shown in other additional studies and surveys. Are PPIs safe? Well, Dr. B, you probably wouldn't have a slide if they were. But as you can see here, there are several systems as well as diseases that have been associated with prolonged PPI use. So the FDA first came out with several warnings in about 2011 and 2012. You can see their circle on the right with an increased risk of C. diff diarrhea, which used to be a hospital-acquired infection, but now is seen in the community. Especially for older women, there's an increased risk of osteoporosis as well as magnesium deficiencies. And it seems like every year since then, there's been a new body system that's been affected by long-term PPI use. You can see their increased risk of heart attack, pneumonias, vitamin B12 deficiencies, even dementia, and more recently, even pancreatic cancer. And then likely most of you recall that last year there was big news made out of that even the H2 blockers may be unsafe, as several popular pharmacies and large chain grocery stores remove these drugs from their shelves. So do medications actually stop reflux? All right, so this is a study of 50 patients with documented Barrett's esophagus, so meaning they do have reflux disease. All these patients underwent pH studies both on and off medications. As you can see there on the graph on the right, these patients actually reflux the same amount or the same volume or quantity, whether they're on or off medications. As you can see, the patients that were on medications, they just had a vast majority of weakly acidic reflux. So this just shows you that medications mask the symptoms of reflux disease. They do nothing to actually stop the physical process of reflux, meaning they do nothing to fix that valve. So what restores the barrier to reflux? Well, generally there's three options. The first is the traditional minimally invasive approach, which is the laparoscopic fundoplication, or we call a Nissen procedure. We typically term it the stomach wrap. And then I'm briefly going to talk about some newer therapies, magnetic sphincter augmentation, which is the LINX device, or an endoscopic approach, which is called Transoral Incisionless Fundoplication, or the TIF procedure. Let's start out with the traditional minimally invasive procedure, is the Nissen fundoplication. This was originally described in the early 1950s by Dr. Rudolf Nissen. We've been doing it minimally invasive since 1992. It is done laparoscopically through 5 small incisions in the upper abdomen, about the size of my pinky finger. It generally takes less than 2 hours. Most patients spend 1 night in the hospital, and generally everyone's back to work within 2 weeks. It is 90+% effective in restoring the barrier to reflux, and it stops all reflux, not just acid, but bile, digestive enzymes, etc. Our patients are generally able to stop all of their heartburn medications immediately, and studies have shown it decreases the chance of developing Barrett's esophagus or of having the Barrett's progress and therefore esophageal cancer. But are there downsides to a Nissen? All right, it is a technically complicated surgery. It is an advanced laparoscopic procedure. Studies have shown that if you have your surgery done at an experienced center like Hoag, you can have success rates of over 90%. But if it's done at other community hospitals, the success rate won't be as good. There are side effects. The vast majority of patients will experience the inability to belch or vomit. To most people, that's not a big deal, but we all swallow air when we talk and when we eat. And therefore, if you can't belch, gas or bloating can be problematic. Now, I will tell you that gas and bloating is seen in as high as 60% of patients, and that usually only lasts about 3 to 4 months, is easily controlled with diet modification and over-the-counter medications. But still a small percentage of patients will have long-term problems with gas and bloating. And generally, because of the anatomy that we're distorting, everyone has difficulty swallowing initially. And as a result of that, they're on a very graduated diet, meaning they leave the hospital on a liquid diet. And then usually by 4 to 6 weeks, they're eating fairly normally. So now I want to talk to you about the LINX device. All right, the LINX device is a, as you can see there in the picture, it's a bracelet of rare earth magnets that are encased in a titanium bead. Right? Rare earth magnets are designed to never wear out, and titanium is a very durable metal. The device was FDA approved in March of 2012, and the strength of the magnets is precisely calibrated to restore the natural function of that LES, and yet preserve normal physiologic function. And the current device that we have is MRI compatible up to 1.5 Tesla, which is the strength of the magnet. So LINX allows normal physiologic function. So shown there on the left, you can see the LINX device is placed around that weakened valve. All right, and as you can see there in the middle, it provides a barrier of about 20 millimeters of mercury of pressure. Now I'll tell you that the normal esophagus can generate pressures from 35 to 80, so meaning it has enough pressure to overcome the resistance of the magnets to allow food to pass into the stomach, as pictured on the right. However, normal intragastric pressure is very low at 5 to 10 millimeters of mercury. So therefore, the LINX device provides enough pressure via the magnets to resist reflux. However, if you felt the need to belch or vomit, i.e. increase your intragastric pressure, you're able to do that and overcome the resistance of magnets to belch and vomit if needed. So the LINX procedure, again, is minimally invasive. We use the same 5 small incisions that we would generally use for the traditional fundoplication. However, here we're not altering the anatomy, right? It is an outpatient procedure, as most patients go home the same day. We generally encourage them to get back to a normal diet as quickly as possible. And then again, it allows patients that ability to maintain those normal physiologic functions, to belch and vomit if need be. And as a result of that, the gas and bloating that I talked about that's associated with the Nissen is either severely decreased or completely gone. And then another nice option here is the device is removable if need be. So I want to show you some data that came out from the initial FDA trials. The first graph here is shown as the results of their pH study. And you can see here that the orange bars represent the amount of reflux time the distal esophagus was exposed to acid in these 3 different trials. And you can see the number of patients involved there. Again, the orange bars are before surgery, the blue bars representing after surgery. So you can see that in all 3 of these studies, ranging anywhere from 44 to 100 patients, there was a significantly reduced amount of acid exposure in the distal esophagus. Now, the one thing you'll notice here is that the amount of reflux after surgery is not 0. All right, so the LINX device doesn't eliminate reflux. It basically takes the reflux down to a normal physiologic level. As I noted at the beginning of my talk, there are some health benefits to reflux. On the next slide here, we'll look at symptom control. Right, GERD obviously impacts your quality of life, and the GERD-HRQL score is a it's a questionnaire that really looks at how GERD impacts your quality of life. It looks at heartburn, it looks at trouble swallowing, it looks at regurgitation. And as you can see here in the fourth study that we added, all these studies had scores greater than 20 preoperatively, right, which indicates significant impactment in the quality of life. As you can see in the blue bars, after implantation, greatly improved quality of life in all 4 studies. And then when we look at studies looking at reflux, we want to look at what percentage of patients are able to stop their medications or at least reduce their need for medications. And as you can see here, as you would imagine, if you were designing any trial, you'd want 100% of your patients taking medications prior to the study. So you can see 100% pre-LINX. After implantation, as you can see, greatly reduced dependence on medical therapy in all 4 trials across the board. And as I alluded to earlier, the LINX device really maintains that normal physiology, and therefore there's minimal side effects. You can see in the top 2 graphs, the ability to vomit or belch is greatly maintained up to 4 years from surgery, and I'm talking 96+% in both of those bars. And as you can see there, as a result, the complaints of bloating and gas-associated symptoms are greatly reduced following implantation and sustained out to 4 years. Since the LINX device was FDA approved in 2012, we now have several years of data. And this is the chart here shows a study that was published several years ago looking at the long-term durability up to 5 years. On the left side of the graph, you can see that at baseline, patients had significant amounts of heartburn, regurgitation, dependence on PPIs, and overall dissatisfaction. As you can see, at 1 year following implantation, greatly improved results in all 4 of those variables and sustained out to 5 years. So in closing here, I think the role of LINX, it really expands our options in treating that weakened valve that's associated with reflux disease. It is reproducible, right, with a precise mechanism of action. It is another minimally invasive option in addition to the fundoplication. But unlike the fundoplication, we're not wrapping anything. It preserves normal anatomy. And most importantly, it allows physiologic reflux and the patient's ability to swallow effectively, belch, and vomit if needed. And unfortunately does not limit future treatment options. Moving on to TIF, or Transoral Incisionless Fundoplication. This follows the same principles of traditional fundoplication, although it's done endoscopically. Patients generally have to have a small hiatal hernia, less than 2 centimeters in length. And we're going to create a valve of approximately 2 to 4 centimeters in length, and that's just the length of the fundoplication, which is exactly similar to the traditional fundoplication. Although the Nissen fundoplication is a 360-degree wrap, this is what we call a partial wrap, or 270-degree wrap. So not a little bit different than the Nissen. The device first came out in 2007, and several modifications have been made since that time. And it's generally the device is called the Esophagus device. On this slide here, it just shows you a picture of the overall device, where again it's placed endoscopically, and the endoscope goes through this device. Overall, the procedure takes less than an hour. It does require general anesthesia. But as you can see here in the picture on the right, endoscopically, we're essentially creating a stomach wrap, a partial stomach wrap, again, 270 degrees endoscopically, using these H fasteners. As you can see, they're pictured in blue. So the advantages of this are that it's incisionless. All right, so if you don't have a significant hiatal hernia, again, less than 2 centimeters, this is a very good option for you. Again, patients go home the same day. Again, without having incisions, post-op discomfort is very minimal. Patients generally do well. And it has much fewer side effects, a much better side effect profile than the traditional fundoplication. I'll show you now some data associated with the TIF procedure. This was the TEMPO trial, which initially looked at patients after 3 years after undergoing TIF. As you can see, it was only a small number of patients, just over 60, but 2/3 of them got the TIF procedure up front. Another third were treated with medical therapy. All patients in that medical group then crossed over and got the TIF procedure at 6 months. And the purpose of the study was to really look at, can we eliminate that daily regurgitation? And as you can see, after 3 months of follow-up, right, the vast majority of patients were free of troublesome regurgitation, free of atypical symptoms, and close to 3/4 were free of daily medical therapy. And again, you can see there their quality of life score after surgery was 5, ranging as high as 32 prior to undergoing the TIF procedure. On this slide here again shows that same trial, those same patients that were followed out to 5 years. You can see out to 5 years, 86% of patients still maintained significant relief from their regurgitative symptoms and still a greatly improved dependence, or excuse me, elimination of PPIs at 5 years from surgery. And then again showing the quality of life, as you can see here, scores of 26 and 32 at baseline, greatly sustained at the 5 years with scores in the single digits. So I think TIF is a good option that we have. It's another tool in our toolbox that effectively reduces reflux in a select group of patients. As I said, the nice thing about it is it's an incisionless option with a low incidence of side effects. It is a relatively newer procedure, however, data is emerging to solidify its efficacy, and improvements in the device over time have made the procedure much more simple for us to administer. So I'm kind of wrapping up here. I like to look at the reflux as a disease on a continuum. And so early on, when that valve is just starting to fail, I still think medications have a role. All right, so just because you come to see us doesn't mean we're going to offer you surgery. But as that valve continues to fail, again, patients will start to develop breakthrough symptoms on medical therapy. This is where I think we have some of newer options, such as the TIF and LINX procedure that we didn't have several years ago, that are good options to intervene for when that valve is starting to fail. So patients with mild to moderate symptoms that may or may not be well controlled on medical therapy. And then for those who that valve has completely failed, where it really truly needs to be reconstructed, that's where I think the traditional fundoplication really still has a role. So in closing, hopefully you realize that reflux is not just heartburn, it's a much more serious medical condition that over time that can lead to complications, including esophagitis, strictures, Barrett's esophagus, and unfortunately esophageal cancer if left untreated. I've shown you that medications will generally treat some of the symptoms, but not the underlying problem. Remember, the problem is the valve. And medications do not reduce your risk of developing Barrett's esophagus or cancer. So my final proposal to you is that we do something to fix the valve, whether it's with the traditional fundoplication or the newer technologies such as TIF or the LINX device. Again, I thank you for your time. I'm happy to take any questions at this time. All right, so the first question I have is reflux related to the speed of eating and the temperature of food? It's a very good question. So in general, patients who tend to eat fast may unfortunately swallow a lot of air while they're eating, and that can lead to gaseous distension, and therefore lead to kind of effacement of that valve, which can promote to reflux. There's been no studies that I'm aware of that show that the temperature of food makes a difference, although some people's esophagus can be more sensitive to the extremes of temperature, meaning extremely hot or extremely cold liquids, but not necessarily related to reflux. Another question is reflux related to nerve problems. So reflux is a very complex event. I seem to simplify it around the valve, but obviously esophageal motility, meaning it's just as important that when that reflux comes up into the esophagus, that you have normal esophageal motility to clear those contents back into the stomach. Likewise, it's important to have normal gastric motility, meaning if your stomach's not emptying properly for various reasons, there's more acid sitting in the stomach for it to reflux. So both esophageal and gastric motility are important components of reflux disease. There are various disorders related to degeneration of nerves that can affect the motility of both those organs. So in that kind of indirect way, they can contribute to reflux. Another question I have is, says I am scheduled for surgery. I am nervous what safety procedures are in place. Again, another excellent question. I can tell you that all of the employees at Hoag generally are screened for COVID and have their temperature checked every day. We're generally wearing masks in all areas involving patient care. Currently, our patients are all tested for COVID several days prior to their endoscopies or procedures. So generally, it's a very safe environment for patients to come in and undergo any sort of procedure, whether it's an endoscopy, a manometry, a video esophagram, or even surgery itself.